Welcome to SLP Nerdcast. I'm Kate.
And I'm Amy, and we appreciate you tuning in. In our podcast, we will review and provide commentary on resources, literature, and we'll discuss issues related to the field of speech-language pathology.
You can use this podcast for ASHA professional development. For more information about us and certification maintenance hours, go to our website, www.slpnerdcast.com. SLP Nerdcast is brought to you in part by listeners like you. You can support our work by going to our website or social media pages and contributing. You can also find permanent products, notes, and other handouts, including a handout for this episode. Some items are free, others are not, but everything is always affordable. You can also submit a call for papers to come on the show and present with us. Contact us anytime on Facebook, Instagram, or at info@slpnerdcast.com. We love hearing from our listeners, and we can't wait to learn what you have to teach us.
Just a quick disclaimer, the contents of this episode are not meant to replace clinical advice. SLP Nerdcast, its hosts, and guests do not represent or endorse specific products or procedures mentioned during our episodes unless otherwise stated. We are not PhDs, but we do research our material. We do our best to provide a thorough review and fair representation of each topic that we tackle. That being said, it is always likely that there is an article that we've missed or another perspective that we haven't shared. If you have something to add to the conversation, please email us. We'd love to hear from you.
I am so excited for today's episode.
I am too. I think it's going to be a really fun discussion.
So every once in a while, when we take on a topic, I feel like I can really contribute. This is one of those times. I am very genuinely interested in scope of competence, and I think it comes up for me a lot in terms of being a duly certified SLP and BCBA and talking about who has what in their scope of competence in terms of different, clinical perspectives. It also comes up, I work a lot with career launchers or people who are recently out of graduate school or CFs. And, when we graduate from graduate school, we're supposed to know everything. We sort of get dumped in to working with all kinds of different populations. And, just like we say in the title of this episode, but I don't know how to do that. I don't know what that is. I feel like that comes up a lot. So I'm really excited to sort of go through the literature and talk about all these kinds of things.
I know, me too. I think it's going to be, it's a big topic. And I think it is not only dependent upon sort of where you are in your career path, but also sort of intrinsic personality characteristics, possibly.
Oh, totally.
Confidence, all of those different things. So
yes. And I think that we're going to touch on that. I mean, most people probably know what imposter syndrome is, or the fear that you don't know what you're talking about, or other people are going to find out that you're an imposter. So that's sort of the other end of the spectrum, right? Like, we're, as clinicians, supposed to be well-versed in our scope of practice. But I think, there's always that personality component of, worrying that you don't know or that you're going to be found out. At least I have that quite a bit. Before we jump in any further, though, let's go through our annoying but required financial and non-financial disclosures. So financial, I am the owner, founder of Grand Bois Therapy and Consulting, LLC, and co-founder of SLP Nerdcast. Amy is an employee of a public school system and co-founder of SLP Nerdcast. Non-financial, we're both members of ASHA STIG 12 and both serve on the AAC Advisory Group for Massachusetts Advocates for Children. I am a member of the Berkshire Association for Behavior Analysis and Therapy, Mass ABA, the Association for Behavior Analysis International, and the corresponding Speech Pathology and Applied Behavior Analysis Special Interest Group.
Well done. Well done. That's a lot of groups.
It is a lot of groups.
Good.
Okay, so learning objectives for today. Number 1, define scope of competence and list at least 2 ethical underpinnings associated with scope of competence. Number 2, describe the relationship between scope of competence, evidence-based practice, and ethics. And number 3, identify at least 2 ways in which a clinician can evaluate their scope of competence and 2 ways in which a clinician can improve their scope of competence in a particular clinical area. We didn't say already, but we should already say that this course can be used for ethics, for the ethics credit that you need. That is confusing because it only starts, like, if this isn't, it only starts to apply during your next certification maintenance cycle. So if you have questions about that, we can maybe put a link on our website. But this episode is more than half about ethics. We're going to be talking a lot about ethics and how being competent in your scope of practice is related to our code of ethics. So you can use this episode for your ethics credit.
Excellent.
I haven't done any ethics credits yet. Have you?
No, because my interval doesn't end until 2021.
Oh, my interval ends this year.
Yeah.
And we can't use our own, I don't think.
I don't think so.
No.
I
It's
don't
a
know.
bummer. Anyways, okay. Moving on. Learning objective number 1. Define scope of competence and list at least 2 ethical underpinnings associated with scope of competence. Okay, so right off the bat, I think it's worth identifying that the term competence is really difficult to define. Like, what does it even mean to have something in your scope of competence? That's really sort of at the heart of a lot of what we're going to be talking about today.
Well, and it's a pretty relative term. Like, I don't think it's not like mass, it's not something that has a very finite scientific definition. I think that, within the realm.
Oh, you mean when you say mass, you mean like weight?
Yes, that's
I
what I
thought
mean.
you meant mass as in like the state of Massachusetts.
Oh, no, that would be, I suppose that has a finite definition as well. You have like borders and everything else.
Like, what? All right, go on.
I was
Say
thinking like
that again. It will make more sense to me now that I know what you're talking about.
Yeah. So, it's not something that has a very discrete definition. Competence.
Right. And I think, back to what you said earlier about, individual, not necessarily personality, but individual perspectives, that being competent can mean a lot of different things to a lot of different people because of, the way people reflect on their own skills, the way people, whether or not they feel that they're educated, comparing their own education to the education or experience of their peers in their work setting. So you might feel that you're competent compared to one set of individuals or professionals, but you might not feel competent when you go to a conference and you're standing around with a whole bunch of experts who have been studying it for years and years and years. So competence in and of itself is a spectrum.
And I think, there's the concept of who's assessing competence, which I'm sure we'll talk a bit more about later, but it's one thing to assess your own personal competence in an area. It's a different thing to apply that lens to somebody else. So competence has the potential to be a loaded term.
I suppose you're right. I also think that it's not something that, at least for me, was hammered home a lot in graduate school. So, in the beginning portion of my career, I left graduate school knowing a lot more in some areas than I do now. I had general information about our entire scope of practice as a speech pathologist. I also felt like I didn't know anything because I had very little hands-on experience. And my clinical skills and clinical confidence grew the more experience that I had. And I knew our code of ethics and I knew the practice documents that we had to review as part of the praxis, but I'm not really sure I had a good grasp of how to grow my scope of competence or how to grow a specific skill set. You graduate and you're sort of like thrown to the wolves.
Well, and I feel like your scope of competence is almost to some degree relative to the role that you're expected to play as well.
Mm-hmm.
I think when I think about scope of competence, I sort of think about the medical model, at least in the United States, and I think about the general practice physician, right? So many of us leave grad school having this very broad surface knowledge, right? We know a little bit about many, many, many things. And then some of us go on to really broaden that knowledge and know very deep information about a smaller number of things. And that almost prunes out some of those,
Yes.
Areas that we had surface knowledge about before. And I think, what is competent for my general practice physician is knowing when to make an appropriate referral in the case of some things, right? So she might refer me to a dermatologist, like, oh, that looks a little funny. You should go get that checked, right? But she doesn't need to know she doesn't need to know everything about,
because she's a general practice clinician.
Right.
I think that's such a good parallel. And I do think that many of us, particularly those of us working in schools or working in clinics, we are sort of expected to be generalists and specialists at the same
Right.
time and we'll talk about this a little bit later, because of productivity standards and administrators, you treat what walks through the door, you treat who goes on your caseload. And I think that instance where you get a disorder or someone with a background that you're not familiar with or an age you're not used to treat, whatever the factors are, it can be really intimidating to think, okay, I'm expected to be competent to treat this individual, but this is not something that I know. I don't know what I'm doing.
Well, and I think that's where, we talk about scope of practice, and scope of practice is really defined by ASHA, and that gets at like all of those sort of broad areas where we might have surface knowledge, right?
Right. That's a perfect segue into my next point. So I think a good place to start, you're looking at, it was no accident. You looked at my notes. the, you know, I think a really good place to start is to delineate exactly that. So let's talk about the difference between your scope of practice and your scope of competence. And then within those two things, how that relates to your particular role in your workplace. So this was one of the first documents I reviewed while we were writing this episode, the ASHA Scope of Practice document from 2007 sort of talks about what a scope of practice is. So it's a statement of purpose. It's a framework for research and clinical practice. It outlines the qualifications of an SLP. It outlines professional roles and activities of an SLP, and it outlines different practice settings. It's a really comprehensive document, the scope of practice document. It's on our website, and it's on ASHA's website, and it can be found as a link in our references. It's about 17 pages long. It lists everything from what qualifications we need to have as SLPs to what kinds of settings we might work in. And it also lists different clinical services that we can provide: treatment, assessment, screening, et cetera, et cetera, et cetera. And this is the piece I think most people are familiar with. It lists the different clinical areas in which we practice. And in case anyone needs a refresher, they are speech sound production, resonance, voice, fluency, language, cognition, feeding, and swallowing. So those are the clinical areas in which we work within our scope of practice.
It's a lot of areas.
It's a lot. It's a lot. And to Amy's point, I think we're good examples. Amy and I are both employed as AAC specialists, quote, AAC specialists. We have been doing nothing but AAC for 10 plus years each. Some of these scope of practice areas for me, resonance, I could maybe point out where different A&P related structures are that would affect resonance. I can't explain the science to you.
Hashtag uvula soft palate.
Anybody remembers the episode where I admitted I can't remember what the uvula does, you can write me angry DMs later. But feeding and swallowing, totally outside of my scope. It's in my scope of practice because I am a licensed speech pathologist, but I no longer work in that area. And as you develop, as you move along in your career and you may become really specialized, a lot of this knowledge, what terminology did you use, gets like sheared off. Those neurons died. I don't have that knowledge.
I was thinking of like roots in a pot and they'd like get pruned off. I do think, I would challenge that a little bit and just say that while you don't have that same level of deep knowledge, you would probably still know, like back to the.
Are you giving me a compliment in the package of I'm going to challenge that?
Yeah, I'm going to challenge you with a compliment. And that is back to the general practice physician. I think that you would still, in all of these 7 domains that you listed, you would help identify that a referral may or may not be appropriate.
So, that's true. I mean, we know more than the general population. Yes. However, in a workplace setting, if I was asked to be competent in treating one of these individuals, I would have a panic attack because it is, and again, what is competence? Am I competent because I have this licensure and I took that course in graduate school 15 years ago? What would make me competent to treat that disorder? So again, thinking big, this is what our scope of practice is as defined by this 17-page scope of practice document at ASHA.
And I think the point that you made right there too about treatment, I think is helpful to consider too, that there is competence within the different types of clinical service that you might provide. You quite probably are quite competent to make appropriate referrals, right? You might not be competent to provide treatment, but you might be competent to provide treatment if given support by somebody who is a specialist, right?
Mm-hmm.
So could you implement somebody else's treatment plan, in consultation with them? Probably. And then assessment is also separate. So I think too, when we're thinking about not only scope of practice, that within the scope of practice, there are all these different types of job tasks, some of which you may have the competency for already, some of which you may have the competency for with a certain level of expert support, and some of which you're like, oh no, that's just a no for me.
Right.
So
I think that's where I fall. It's just a no. It's just a no for me. So what's interesting, sort of piggybacking on that, is that this document, the 17-page document, it does state that there are varying levels of skill within each of these domains, and that most SLPs typically don't practice in all areas of the field. That's not something, we don't. And so yet, you have individuals who are becoming employed at and working very much as generalists, being expected by their administration to treat whatever walks through the door. And I know that that's a very crass way of saying it, but I think it gives you, you get the picture. And yet our own governing body, ASHA, acknowledges that most people don't treat anything that walks through the door. Most people don't work in all areas of our scope of practice. The scope of practice document references our code of ethics a lot. And we really when you go in that document, you really start to see where scope of practice and ethics start to overlap a lot. Our code of ethics gives us a lot of guidance about how we're supposed to conduct ourselves in relying on our competence. And actually, the word competence shows up in our code of ethics a whopping 17 times. 17 times.
When I read that in your notes, I was surprised because that is a lot of times.
It's a lot of times. Now, to be fair, that's an inflated number because we hold C's, Certification of Clinical Competence. So the C at the end of your name, every time you sign your says that you are competent in this scope of practice. But again, what does it even mean? How do you define whether or not you are competent? So we work so hard for these C's, and our code of ethics says over and over and over again that we need to be competent. And I thought it would be really helpful to sort of dive into the code of ethics and really review once again, what standards are we being held to within our ethical code as far as competence is concerned, aside from having a C after your name that stands for competence. So principle 1A, individuals shall hold, rewind. Principle 1A, individuals shall provide all clinical services and scientific activities competently.
Right there in the first one.
So you have to be competent, even though there's a quite, as we've already said, quite a spectrum of like what makes you competent. Principle 2A, individuals who hold the certificate of clinical competence shall engage in only those aspects of the profession that are within the scope of their professional practice and competence, and considering their certification status, education, training, and experience. So for the first time, we get a little glimpse about what competence might mean. And it's really, so we know now, based on this principle 2A, that competence is related somehow to professional practice, certification status, education, training, and experience.
Yeah, it's like in my head when I read it, it's a Venn diagram, right?
That's the circles.
Right. Yeah. So one of the circles.
I'm not competent in graphic displays for organizing knowledge. Infographics are not within my scope of competence. Sorry.
So on one circle, you could imagine those 7 domain areas, right? Speech, sound, production, resonance, voice, fluency, language, cognition, feeding, and swallowing. And then on the other circle, you have all of the related competency skills, right? Assessment, identification, referral, all of these different things. And only in some places do they overlap. And my overlap is going to be different from your overlap, is going to be different from somebody else's overlap.
Right. And I mean, in terms of, what's different. So I think certification status is interesting because what we're talking about there isn't necessarily being certified as a speech pathologist, but we have subspecialties within our field. So you can be certified, in fluency. I know we've had our, resident feeding and swallowing person, Tracy Callahan, on here before talking about, as an example, with feeding and swallowing certification, you don't have to be certified in feeding and swallowing to be competent to provide that service. So specialty certification is only one possible way that you could deem yourself competent. There's also education, training, and experience. I think education and training are a little bit more straightforward because there are actual conferences you can go to, courses you can sign up for. But the training and then maybe mostly the experience is, I think, there's a really wide berth there of what's expected. So will give you a little storytelling time. I worked with a speech pathologist once who was early in her career, and she had a lot of strengths, and she was not a good fit for her employer, and she was let go. And she decided that she was going to be in private practice doing only AAC services. And she had had, I think, maybe one student or client with an AAC device before. And what was unfortunate about it was that she told everybody that she was now an AAC specialist and that it was in her scope of competence. Now, to me, it felt, again, who am I to say? She could have gone to conferences that I don't know about. I don't know. I'm not going to, it's easy to throw stone in a glass house or whatever that expression is. I'm certainly not passing judgment. But what I knew her experience because I was working with her in our job setting and I was mentoring her. So I knew what her experience was. And I was not a privy or aware of any experience she had that made her competent in the field of conducting AAC evaluations. But there are all of these other ways that you can define competence. And I think that that's a really, really important point. And that little anecdote is related to another principle in our code of ethics that we will get to in a second. So principle 2D, individuals shall enhance and refine their professional competence and expertise through engagement in lifelong learning applicable to their professional activities and skills. This is a huge one. We know that we have to get 30 hours of continuing education every 3 years, but why? Because you need to be competent in your skill set.
And one of the things that I love about this one is that it acknowledges that competence is not a static place. It's not a thing that you achieve and then sit there in the land of competence in a certain area, because our field has an evidence base that's constantly growing. Things are changing, new information comes in, and we need to integrate that into our clinical practice. So I really like this one because it also indicates that competence isn't a set static achievement. It's something, that is an ongoing process.
It's lifelong learning. So, and I think that that's especially true in this day and age where research is constantly changing, information is constantly changing. You might be competent. I particularly feel this way about the field of AAC because technology is always changing. So, if I don't go to conferences or really dig my heels in for continuing education for a 3-year period, I feel I'm out of the loop. I'm no longer competent. And I mean, that's AAC, but that's true for any field where there are additional components of continuing education that we need to constantly be reminding ourselves of. And we're going to talk a little bit about that interplay between competence and evidence-based practice in a minute.
Well, and I think, those lifelong learning activities may or may not have to be structured conferences. There are a lot of different ways to learn things. And, that could be through mentorship, that could be through reading, that could be through podcasts. So, a lot of it is just acknowledging that mindset of being a learner,
right,
and looking for those opportunities.
Right. Principle 2E, it goes on and on. Individuals in administrative or supervisory roles shall not require or permit their professional staff to provide services or conduct research activities that exceed the staff member's certification status, competence, education, training, and experience. This one is huge.
Can we like get a like a commercial for this?
Well, I don't know if we can make a commercial, but we can talk about it and record ourselves and publish it like we're doing now. I mean, I think that this is, if you have a supervisor or an administrator who is also a speech pathologist and they are requiring you to provide services that you feel are outside your scope of competence, that is an ethics violation. Plain and simple, based on Principle 2E. Let's read it again. Individuals in administrative or supervisory roles shall not require or permit they won't let them do it, their professional staff to provide services or conduct research activities that exceed the staff member's certification status, competence, education, training, or experience. Now, I think what's hard about this is that, let's say someone went to their supervisor and said, I don't feel competent. When we get to learning objective number 3 and we start talking about evidence-based practice and what scope of competence actually means, I think it would be very difficult to prove that you don't have something in your competence, because there are a handful of things that you can do in terms of data collection to sort of make sure you're staying ethical. In other words, you could certainly approach your supervisor about it, and please do, and please tell them that you're concerned about violating your ethical code, because that is a very legitimate concern. But it's still possible to remain ethical by taking, a little bit of action that we will get to later in the episode. If that makes sense. Now, moving on to the last main principle, the last principle that specifically calls out scope of competence, Principle 3A. Individuals shall not misrepresent their credentials, competence, education, training, experience, and scholarly contributions. Now, this is the one I was referring to with that little anecdote of the woman that I knew who went into private practice. Now, I am not in any place to tell someone what is or is not in their scope of competence. However, this individual was advertising her services as a quote specialist without many years of clinical experience. And I said nothing. I didn't necessarily feel it was an ethical violation, but it raised an eyebrow. And I think that there is a very fine line between actively seeking out information to become competent, because like you said, it's a dynamic, lifelong experience, and representing your scope of competence to the public in exchange for services or seeking services.
Yeah, I think that is it's a qualitative, it's not a quantitative term, it's a qualitative term, and it makes it really challenging. And that's why I don't have any good references offhand. But in terms of AAC, you will see, I've seen on multiple websites, like, here are some good questions to ask your speech pathologist. Just like your best advocate at the doctor's office is you. Like, ask your doctor questions. Don't assume that your doctor is the best doctor. Ask them questions that are relevant to you. Go in with notes. I think that is a good consumer advocacy skill for everybody. Mm-hmm. To be aware of, what are some things to look for. And some of those things might be helpful as clinicians for us to read as well, and kind of ask ourselves those same questions. Like, flip the dynamic a little bit and think about yourself instead of the provider, but as the consumer. If I were the consumer, what would be some things that I would feel like would be important for me to determine that my speech language pathologist was competent in this area? Right.
So thinking about the big picture again, we have to be competent in our clinical skills. We have competence in our C, that, it's one of the words in our C's. It's listed in the Code of Ethics a bajillion times. We have to continue working on our competence. We can't let our supervisors, we can't let our supervisees or our mentees engage in clinical work outside of their scope of competence, and we can't misrepresent what we are competent in. So Amy sort of mentioned the Venn diagram before, but if you think about our scope of practice as like a big circle, and in it are all of the different things that we can do, dysphagia, language. See, it's not in my scope of competence to say that word correctly. Language, cognition, fluency. And then within that big circle, there's a smaller circle, and that is your scope of competence. So you're an SLP, you know your code of ethics, you know from the ASHA scope of practice documents that you likely won't work clinically in all the different areas of your field, and you know from your code of ethics that you have to be competent, which leads us to the big question. How do you know what competent is, and what does it even mean? We found a great article written by William Mustaine, I believe is how you pronounce his last name, called The Ethics of Competence, and it was published in the ASHA Leader in June of 2003. We're going to talk about this article in a little bit more detail when we go through our third learning objective. But the article basically reiterates what's stated in the ASHA scope of practice document, that competence is a matter of competence is a matter of clinicians self-evaluating their education, training, and experience. And this is really one of the most specific definitions of competence that I could find in the literature, that it's an interaction between education, training, and experience. And the main point of this article is that this is vague, that this article calls it out. The defining scope of competence is a vague and difficult thing to do. And it varies. It varies widely. So my competence is going to be very different. Amy and I work very closely together. We basically have the same job, but our competence is going to differ based on the experiences that we've had with different clinical profiles, ages, equipment that we've worked with. There is a lot of individual variance in what makes you competent, which is why it's very important that a clinician knows how to self-assess their competence. And before we sort of get through that and get to that in terms of how to self-evaluate and how to seek more information, I think we really need to talk about how this is related to evidence-based practice, because it is. Learning objective number 2, it's a quick segue, describe the relationship between scope of competence and evidence-based practice. So evidence-based practice is something that I think almost every single clinician with their Cs knows, that we're supposed to be providing evidence-based practice. It's a requirement in our field, and it's rooted again in the code of ethics. So once again, we're going to go trudge back to the code of ethics and talk about why. Interestingly, the word evidence only appears one time in our code of ethics, just the once.
Well, hopefully it's a meaty one.
I don't know if it's meaty. It's just one sentence. But thank you for your contribution. Principle 1M. Individuals who hold, I'm still laughing. Principle 1M. Individuals who hold the certificate of clinical competence shall use independent and evidence-based clinical judgment, keeping paramount the best interests of those being served. Now, I know it's just one sentence. It's meaty. It's a meaty one.
It's like, I would give it like medium meat.
You think it's medium?
I mean,
medium plus.
I'll give it medium plus.
Medium plus meatiness?
Yeah.
I think that that's fair. I think it's important because you're using evidence-based clinical judgment, keeping paramount the interests of those being served. I also think that the term clinical judgment is so vague and could be easily misconstrued. So when
Hence the medium.
Hence,
meatiness.
But what I like about it is that it's evidence-based clinical judgment. So if you are having a clinical conversation with someone and you are challenging their clinical judgment, they need to have evidence as to how they came up with that piece of information. And ASHA has a whole bunch of information on evidence-based practice on their website. We're going to post some links there. I went deep reading it. I don't think I had ever read it so carefully. But ASHA basically defines evidence-based practice as the intersection of 3 things. And if you can sort of imagine a triangle, right? And they sort of all prop each other up. So on one side, you have client's perspective. This is the evidence-based practice triangle. You have the interaction between client perspectives, internal and external evidence, and clinical expertise and competence. So this is where we really get into how competence and whether or not you are competent is how it's related to evidence-based practice. So let's go back and talk about each one of those individually. Number 1, client perspectives. This is the values and perspectives, cultural background, goals and expectations that have been identified by your client or their caregivers or their stakeholders. So clinicians, and we're going to talk about this in more detail in a minute, but we are required using evidence-based practice to consider all three of these things. This is a really important one, and I think something that a lot of people do very naturally. We don't work in vacuums as speech pathologists. Number 2, ASHA calls internal and external evidence one of these three pillars of evidence-based practice. I think this is what most clinicians think of as what we see in articles and literature, but that's the external part. So again, internal and external evidence. But in recent years, there's been a shift here, and around 2007, ASHA started embracing what they call, quote, internal evidence. And the internal evidence is your client's measured response to an intervention that you are providing. So you have your client perspectives. There's your one side of the triangle. Then you have your external evidence. Okay, you read these like 3 or 4 articles about blah, blah, blah. You looked at, whether and what the outcomes were for that population. Is that population representative of the client that I'm actually treating? That's your external evidence. But now internal evidence. This is relatively new in our field. Is your client making measured progress? Are they having a measured response to the intervention that you're providing? There's a great article by Jeff Higginbotham and Antara, and I'm pretty sure it's pronounced Sachidanand. And this article was published in the ASHA Journals Academy in 2019. And it explains this transition really, really nicely between external and internal evidence. And it's really worth a light read. It's like all of, a handful of paragraphs. It's not very long. But what's really nice about it is the emphasis on, instead of just reading a couple of journal articles, which you absolutely should do, collecting your own evidence about the treatment that you're providing is another way to provide evidence-based practice. And I think that that's really important. And not to belabor the point, but data. We talk about data so much on this podcast because of how important it is, and using data to reflect client progress and make informed treatment decisions is part of evidence, your internal evidence.
And I would argue that if you're working with lower incidence populations, that almost becomes in some ways more important than the external evidence, because chances are that external evidence doesn't map super closely onto your actual clients with whom you're working, right?
Yes.
So that external evidence helps give you the idea of what you might try, but what you really want to pay attention to is, what is this actually doing for my client? Because that is what ultimately matters.
Right. And I think what I really like about what ASHA says here is that this is a really dynamic process. So we need to be constantly reevaluating our treatment based on progress, changes in medical status, stakeholder needs. And they even recommend a trial period, which I absolutely love. So during the trial period, you make recommendations, you're applying a certain treatment and taking data on the internal evidence, reevaluating and readjusting your plan based on outcomes.
Well, and I think for those of us in the field of AAC, this actually isn't a new idea.
Right.
We do
but
trial
applying
periods
across the board is just brilliant genius.
Yes.
And thank you, Asha. I don't get to say that
Yes.
often, but thank you for spoon feeding me this tiny piece of information as we were just doing this research. And for the sake of saying it again, data. This is why data is so important. So we have
Get down and dirty in the data, because
down and dirty in the data.
help inform your evidence-based practice.
Right. So, but getting back to the point of this episode, how does this all relate to competence? How does this all relate to providing competent services? So going back to our triangle of evidence-based practice, on the one hand, we have client perspectives. On the other side of the triangle, we have internal and external evidence, which is journal articles, but also your client's own measured response to your treatment. Third and final side of the triangle, clinical expertise and competence. So this is where ASHA specifically makes the connection and the relationship between our scope of competence and the application of evidence-based practice. So not only does our code of ethics specifically call out that we have to be competent, that we have to hold our supervisees competent, that we have to continually work towards competent, and all of these other things. But in order to provide evidence-based practice, you need to be competent in the clinical services that you are providing. So a lot of this is somewhat straightforward, but we still sort of have this lingering question of clinical expertise and competence. In the ASHA evidence-based practice, I guess it's a portal, I don't know, webpage called Making Your Clinical Decision. They recommend that clinicians assess the appropriateness of clinical experience for a specific situation and consider your clinical expertise and the expertise of others while you are making clinical decisions as part of evidence-based practice. So again, we have another reason to effectively evaluate our scope of competence without a whole lot of direction, right? So it's sort of coming back to that idea, what does competence even mean? And I know we've spent most of this episode at this point just still answering the question and shining a light on all the places where we find this question, but it's really important because now we have a whole list of ethical reasons why we have to be competent and a whole list of of ways that it's indirectly related to our code of ethics because we can't provide evidence-based practice without areas of clinical competence. And ASHA specifically states in terms of providing evidence-based practice that we need to assess our own clinical experience and consider our own expertise as well as the expertise of other people when providing evidence-based practice.
I think that is such a good point, right? And the way that it maps onto evidence-based practice. And I think that when we're being self-reflective as a clinician, we're identifying places that we have, room for more growth or greater growth than other areas. And in doing that, we're able to integrate that into the evidence-based practice, triangle. When you conceptualize that evidence-based practice triangle, growing your competence is kind of always at the top of that. I guess that's where I'm putting it in the pyramid. It's at the top of the pyramid.
Yeah. No, that makes perfect sense. So I think this is a really nice segue into our third and final objective where we've been asking questions this whole time and pointing out problems, but let's talk about some solutions. So learning objective number 3, identify at least 2 ways in which a clinician can evaluate their scope of competence and 2 ways in which a clinician can improve their scope of competence in a particular clinical area. So let's go back to our original question or our original clinical scenario where you're a new grad or even, a mid-career speech pathologist and you get a job and you're working in a school or a hospital. And no matter how many years of clinical experience you have, you feel really confident in your role. And then all of a sudden, a student, a client, or a patient gets put onto your caseload with a diagnosis you've never seen or a disorder that you've never treated. And you have to be ethical and you have to be competent, but you don't know what to do. This has happened to me. This happened to me a lot because when one of my first jobs out of graduate school was in a hospital setting, and the administrators were like, well, you have productivity standards, so we're just going to schedule people on your caseload. And I would get a chart 15 minutes before I would see this individual and be like, okay, well, just buckle up. Here we go. We're just gonna, and it's an incredibly anxiety provoking experience.
I think that it makes me think of times that I've worked in outpatient, and I think that does tend to go. I've experienced that more frequently in outpatient environments than I have in other work environments, and I think in part that's because of the broad spectrum of individuals who are receiving service in that type of location. So again, back to the environment as a player in all of this, the expectation of that environment is that all SLPs who are there have at least some surface knowledge that's broader than the expectation in a lot of other environments.
And I think just such a good point because I was lucky enough to work with one of my first jobs, I had one other SLP and she had the same amount of experience as me. In my other job, I had 9 SLPs and they were all way smarter than me. They were all more seasoned than me. And I would stick my head in the hallway and be like, help, does anybody have an idea? So I think you're right. The environment plays a really, really big role. And there are a lot of other barriers to whether, how you can assess and manage your own scope of competence. So, number one, we already sort of touched on a little bit productivity and administrative standards. So, an administrator doesn't necessarily know the level of subtlety and specifics and ethics in our field. So, when I was working I've worked in a handful of different outpatient, but also clinic settings, and my bosses were often PTs or no clinical experience. They, were trained in business. Um, and well, you're an SLP. This is what you do, isn't it? This is in your scope. So we expect you to treat this patient and we expect you to bill for it. That's a really big barrier. Another barrier is funding. Funding is always a barrier. I feel like most SLPs don't have productivity time written into their caseloads for additional training, for additional mentorship. I mean, my personal experience, one of the only reasons that I got trained in AAC was because the clinic that I worked for got a big grant and they bought a bunch of my time and paid for me to go to, they bought me a mentor. Her name was Amy. And she taught me everything she knew. But, that funding came from somewhere. They sent me to conferences. I got to spend like half of a day during the week just playing with devices and tinkering, but that was a funding solution. I mean, that came from a grant. So funding can be a really big hurdle to improving your scope of competence.
Well, because when you think about it, money is time, and it takes
Yes.
time to learn new things
Yes,
or to
totally.
reflect on things and to know them more deeply. All of that is connected with time.
And as we've already talked about in terms of our scope of practice and these 7 different practice areas, each one of those areas has years and years and years and years and years of research to review. And each one of those areas can be its own subspecialty. So, in terms of judging your own competence in one of those areas, that can be, there's a deep hole there that you can go down. And at what point in that rabbit hole do you determine that you are actually competent?
Well, because the flip side of this is like you did go to undergrad and grad school and passed a board exam and got your C's because
Right.
you completed your CF. So, you hinted at this at the beginning. The flip side of overreaching with your competence is, thinking you don't know anything. And that's not true. That's not true for anybody who's
Is my
listening.
imposter syndrome showing? Is that what
Yeah,
you're
don't
trying to
let
tell
your
me?
yes. Well, don't let it get in the way of, nobody is perfection. We're never perfection. We're
It's a
all a
lifelong
work.
process of learning, says our
Yes.
code of ethics. Again,
Yes.
ethics,
Yeah.
ethics, ethics.
Yeah. So it's finding a sweet spot. How do we find the sweet spot?
Right. Well,
Where's the
I think
sweet spot?
this is sort of nice, leads me into my last identified barrier, which is credibility. So we don't want to admit to anyone that we don't know what we're doing. To your point, you took this board exam. Asking for help is not something that's going to make you seem like you know all the things and that family feels super comfortable being treated by you and your administrators think that you're up for a raise because you know everything, right? Credibility is a really, really important component.
But it's also a balance. I think that there's a sweet spot there too. Obviously, you're the expert. Obviously, you have extensive training, and then whatever degree of training you have in your particular practice area, you want your clients to feel comfortable and confident in the services that you're providing to them. But something that, for me at least, engenders more confidence is having somebody who's able to admit, I'm not sure about that, but I know
Totally
where to
agree.
look. I'm going to do some research. I'll circle back with you
Knowing what
in
you don't
X amount
know.
of
Yep.
time.
I think
And
that's a great balance.
because it's an unrealistic expectation and it's an unfair expectation for us to place on ourselves or for us to imply to our clients that we know all the things. That's impossible. It's
Mhm.
impossible to know all the things. It's okay to say you're stumped. It's okay to say you'll look into it. I think all of those things are actually very healthy things for us to do.
I think I've said this on our podcast at some point before, but knowing what you don't know is a cornerstone of professional maturity. And it's okay to admit maybe you don't want to tell the family, well, I've never seen anyone like your child. So there are certain things that you, in terms of credibility, but knowing what you don't know so that you can seek the information is one of the ways to gain competence in a skill area. If you are saying, well, I know everything and you don't know what you don't know, then you never seek the information, you never gain the knowledge and you don't learn. So this sort of brings us back to how you can assess your own scope of competence. So we're going to go back to that Mustaine article from 2003. He has some really good suggestions for this. Um, uh, Number one, he recommends reading the Scope of Practice guidelines, which I reread in preparation for this episode. And I do think it helps to be reminded of the different environments that you're expected to treat in, obviously your scope of practice areas, the different kinds of service, and what qualifications we do have as speech pathologists. I think that that's a really nice way, a good entry level. If you're really looking to assess your scope of competence, go back to your scope of practice guidelines and just get a feel for who you're expected to be as a speech pathologist in general. The second one I thought was a really great suggestion, which is reading position statements about a particular practice area and determine how much of that information is new to you. So if I were to go into the Fluency Practice portal or read position statements on, any of the scope, really much anything outside of AAC and complex communication needs at this point, a lot of it would be new information to me. And I would be able to say to myself, wow, there is a lot here that I don't know. I am not feeling very competent in this area.
I think that this point is awesome, right? We already have metrics available to us to help quantify this kind of nebulous qualitative idea of competence nicely. And one of those things is from ASHA, and it's the different position statements in all of our different practice areas. And there's another one that you found too.
Another one, what? Another
thing that
item?
we can read and think about.
Another thing that we can read and think about?
Yeah.
So the last one that he mentions in this article is reading the knowledge and skills practice policy documents for the different clinical skill areas that you're interested in, and sort of conducting the same self-analysis of how much of that information is new to you. I will say, I don't get to say thank you to ASHA a lot. However, they have a lot of information on their website. And I think that this is why we pay them so much money every year. I'm not sure. But, these are documents that are there for us to consume to help guide our practice. And I think in terms of defining scope of competence, this is where it's at.
I've got to say, the knowledge and skills documents make me feel all right about all of that money.
You're feeling all right. Da, 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 da. I don't get to sing often on here, but I just
this is
did.
good. When is the last time you sang? This is a special.
I don't know. It was a long time ago.
Oh, I feel like I should remember.
Not feeling too good myself.
Be together.
I'm going to have to listen to that when we're done. But yes, I mean, it makes you feel a little bit better about paying your dues every year when you are, in a position where you're not feeling competent and you have access to so much of this information at your fingertips.
Well, in being I like to quantify it and put things in boxes type of person that I am. That's just how my brain works. Even thinking about reading the knowledge and skills practice policy documents, they have all of these great bullets in there, right? All of these different bullets of things you should think about. You could even read that with the lens of just a very simplified Likert scale to be like, rarely, sometimes, frequently, and think about how often those different bullets apply to you, right? So how often does this thing happen? Is it a rarely, frequently, sometimes? And if you find most of your scores are in that rarely, sometimes, perhaps you're not as competent, and that's a place for you to really pursue additional growth if that's somewhere that you need to.
And I know that this sounds like a pain in the butt, but you are ethically obligated to be competent and not misrepresent your level of competence. And your administrators, if they are speech pathologists, are ethically obligated to make sure that you are competent. And I think that this is a great way a great place to, if you are this example clinician we're talking about who's been given a client or student that you really don't know anything about, then this is a really great place to start in terms of self-advocacy and having those open conversations with your administrators and trying to find time in your schedule to do a little bit of reading and do a little bit of digging. So in terms of self-assessment, I think this is where you start, is reading some of these policy documents, reading some of these knowledge and skills documents. And the last one, this wasn't in the article, but something that I would recommend is reach out to your colleagues. Ask other people questions. The people who work with me, shout out if you're listening, they're probably not. They're like, oh God, we have to listen to her talk at work all the time. But how many times at work have I said, oh, I don't know, let me ask Amy, because I ask you everything. Or I'll be like, oh, I don't know, my friend Tanya might know. Hi, Tanya. I don't know, but I do have access to friends and colleagues who I do know. I see tons of questions being posted on social media. I have mixed feelings about that, but we live in a time of of social connectedness. So, I'm just as a disclaimer, I am not recommending that you post client information on social media. I am not recommending.
Definitely
I
don't.
am not recommending, but it is possible to make friends on the internet. It is possible to Google an author of an article. I do it all the time and ask them a question. You can seek information by connecting with colleagues, I guess is the main point. So now that we've talked about how to assess your own scope of practice, and let's go back to that clinical scenario where you don't feel competent and you've done a self-assessment, you've identified that you need to improve your clinical competence in a specific area. How do you do it? Aside from reading a lot of those skills and policy documents. So remember that triangle, that evidence-based practice triangle where we have client perspectives, internal and external evidence, and then clinical expertise.
At the top, if it's a triangle.
At the top, right. We sort of referenced earlier, we were going to talk about this later, but this is where evidence-based practice, the flexibility of the evidence-based practice triangle can really come in handy because all of those different components work together dynamically. And they make it clear on there that sometimes you might need to rely on one or more aspects of the triangle. You need to consider all three, but there may be moments where you are not an expert in this area. Your area of clinical expertise isn't maybe an experience, maybe isn't as high as you would like, but you can rely on stakeholder input, internal evidence, and external evidence to help you make your decision. So if you're not feeling very confident in your competence, and you've read the knowledge and skills documents, you can collect data on your client's performance. You can you can use that triangle a little flexibly to rely on other components of evidence-based practice while you build your competence in that particular area. ASHA's evidence-based practice guidelines suggest that they have a decision-making process that has a cute little acronym DECIDE, DECIDE. And it just stands for define, extrapolate, consider, incorporate, develop, and evaluate. There's a link to this on our website. I think that this is a really nice and succinct set of steps that can help you make informed clinical decisions so that you can remain ethical and remain in compliance with our code of ethics and provide evidence-based practice when you're not feeling particularly competent. So definitely check that out. Define, it stands for define, extrapolate, consider, incorporate, develop, and evaluate. Another way that you can improve your scope of competence is join a special interest group. Those special interest groups are massively helpful.
Shameless plug for the SIG. Yeah, Kate and I are both members of SIG 12, and we get no bounce back from ASHA for this. But I will say I've been a SIG member for many, many, many years.
Many years. The one part of the SIG that I have found the most helpful is the emails.
I like the emails.
You get on an email thread, and maybe I'm not explaining this properly, but it's basically other people who have written in questions, and you get to read other people's questions and read the other answers. So it's this nice collective, like hive mind of information. Hashtag Ender's Game, Speaker for the Dead. Just a slight nerd moment for a hive mind. I can't say hive mind without thinking of those books. But anyway, so it's this really nice, portal into the thoughts of so many other clinicians. And there are really, really, really amazing, intelligent people who participate in the special interest groups. And you can email them. You can email them questions. You can pose your questions to the whole group.
Well, and I think another piece to contrast it with sort of the floating a broad question out to social media and you don't really know, you want to evaluate your source, right? We learned that in grad school. We learned that when you're reading something, there's a difference between a consumer article and a peer-reviewed article. When you're floating questions to a SIG group, you know that it's a self-selected group of clinicians, some of whom are like the famous fancy people who you've read their articles. They might respond to you. Some of them are other clinicians who are actively working in the field. They might respond to you. And it's a little bit different from social media where you don't really know who anybody is, or I don't know, I guess that's just how I feel. But.
No, I think that's very true. If you're able to, you can also refer out. So if you're in private practice, I'm in private practice, I do this all the time. You can make referrals, informed referrals. If you're able to, and this is like my personal one, contact a mentor. Advocate with your employer to have them provide a mentor for you. Mentorship, we have a whole other episode on mentorship called Receiving Critical Feedback, All the Icky Feelings. Maybe we should do another one on the importance of mentorship, because it's something that is a critical component to learning, particularly clinical skills, but something that I don't think is often employed in our profession in terms of a formal mentorship. And formal mentorship, mentorship tends to be sometimes informal, but mentorship is an unbelievably incredible experience. And you can attribute so much of your learning to sharing your experience with another person who might have that area of expertise and you don't. And just to do like a quick shameless plug here, Amy and I are both mentors. And this is a service that we provide to people. So if you are interested in mentorship, or you want to find a mentor, please contact us. Please send us an email. It's something that we're really passionate about, and we would be happy to, try and help you find or connect with someone who is an appropriate mentor to gain additional information in your particular area of expertise. Finally, this one is a little bit more obvious. Continuing education, conferences, going to conferences that have a special niche. So in the AAC world, we have, conferences that are specific to AAC, ATIA, Closing the Gap, et cetera, et cetera. There are a lot of continuing education opportunities out there that are specific to what it is you are trying to learn. We have our platform here. If you can't find a course based on something really specific, send us an email. We will try and put it together for you. But there's so many resources out there for continuing education, and that's another really great place to start.
I think the other piece is just continue to have a commitment to lifelong learning and better understanding yourself as a learner, and identify what modalities are best for you. How do you best like to consume information? We also talk a bit on this podcast just about the need for a work-life balance. In the one hand, we're saying read the knowledge and skills document, reflect upon it, give yourself feedback about where you fall in terms of your level of competence, but also live your life and be a person. So one thing that could be helpful.
Can we put that on a mug? Live your life and be a person. It's hard as an SLP. We have a lot of jobs.
As somebody who's working through a holiday weekend, I can attest that, that shouldn't be the norm. So I think also just being mindful of ways that you can incorporate small moves toward professional development into your daily process. Maybe it is reading an article or listening to a podcast, or reading something on ASHA while you eat your paid lunch or something like that, and you would prefer to do that than explore these things on your weekend. I think part of it is make a plan for it. Make a plan for not only where you think you want to grow as a clinician, but what your plan is to get there. And I think that will help.
We hope that everybody learned something from this very long-winded journey related to competence. It's something that, we feel pretty strongly about. And, it's so important. Our code of ethics is long, and I think sometimes we forget how important it is sometimes to reflect back on the code of ethics and make sure that we are engaging in ethical clinical behavior. If anyone has any questions about any of the content that we covered today, please don't hesitate to send us an email. If you would like a handout for today's episode, one is available on our website. And if anyone has any questions, reach out anytime. Hope everybody learned something. And
we'll see you back here next time.
And we will see you all back here again soon.